Welcome to the Speaking of Women's Health podcast. I'm your host, Dr. Holly Thacker, and I am back in the Sunflower House for a new edition of this podcast with one of our favorite guests, Dr. Kristi Tough-DeSapri, and this is her third appearance. And today we're going to dive into a really important topic, one that I've gotten a lot of questions on, and my nurses have, and our lead nurse said, you have to have Dr. Tough-DeSapri back on the podcast and ask her about traditional bone density scans, some of the newer technology called REMS, or radio frequency echographic multispectrometry. Dr. Tough-DeSapri, as many of you know, is an expert in bone health and women's health. And today she's going to help us understand when and why these tests matter and how they impact your care or the care of a loved one. And as I mentioned, this is her third time on our podcast. We're in season 4. Joining me, she's joined us in season 1 and 2. And all of May is Osteoporosis Awareness Month, but we really focus on women's bone health year round. But before we dive into the interview, I want to share a little bit about Dr. Tough-DeSapri. She is the founder of Bone and Body Women's Health in Chicago, Illinois. She graduated cum laude from Tufts University. She attended medical school at the University of Health Science Center in San Antonio, Texas. She then completed some training and internship in OBGYN at NYU and a residency at Lenox Hill Hospital, and she is board certified in internal medicine. She is a super achiever, one of my top fellows. I've run this fellowship for now 29 years, and she completed her fellowship in specialized women's health at our Center for Specialized Women's Health at Cleveland Clinic. And it feels like it was just yesterday, but I guess you started about, 16 years ago? It was when my oldest son, Stetson, who's now a PhD, he was a senior in high school. And he was in the office when I was talking with you about starting the fellowship and some things. And he thought I was exceedingly hard on you. He's like, I can't believe, Mother, you were that hard on that nice doctor. And I said, well, she's so super smart. And I know she's going to have an incredible career. And so I want her to do the best that she can. And you have certainly done that. And you're married and the mother of 3 sons. And we were talking before we started podcasting that doing women's health all day long, it's kind of nice to have a little difference when raising your family, dealing with boys.
Yes, it is. It's a nice yin and yang.
So welcome to our podcast again, Dr. DeSapri.
Thank you.
You want to just tell us a little bit about bone densitometry? I know you do that in your practice and you're an expert, you're ISCD certified. Why should women at midlife think about getting a bone density?
Great. Well, thank you. Thank you for that introduction. I feel like you give back so much to our community in this podcast and all of the education that we had as fellows. I cannot believe you have been doing the fellowship for that long. And we were just saying how there's many of us, women, I would say, doing, boots on the ground, really great work and research and clinical care and for, all midlife women. So I thank you. You are inspiration to me daily. If you email or text Dr. Thacker, she will get back to you in a minute because she is so dedicated to all of us as well. So we are so thankful for you. So, to answer your question about bone density, I think this is such a great topic. Obviously, my practice is bone and body women's health, and used to get questions like, why bone? And now I don't get those questions anymore because people know that menopause is a revolution, and menopause is more than just loss of our sex hormones from our ovaries and changes like hot flashes and vaginal dryness. Those are the outward symptoms that we can see and signs, but then there's so many changes at menopause. So bone health being one of them. So when you ask me, why do we need to get a bone density or care about our fracture risk? It's because so many women, this changes a lot during the menopause transition. And then in the post-menopause years, right, we're going to live in menopause. A lot of women will live a third or close to a half of their lives in the post-menopausal years. And our bones need to carry us through that time, right? Our bones and our muscles, so our skeleton. And then we know that the conditions of osteoporosis or weakening of the bones can lead to fractures. And that's where that impact happens. So, we've always, from the fellowship and from learning about menopause and midlife back before it was cool, I always say back before I was reading the menopause journal on airplanes, and I used to hide it behind something else because people would look at me strange with menopause. Now, we're singing menopause from the hills, but we've known that, all of these changes, whether we can see or feel them, will impact our life at menopause and beyond. And I think that when I look at my practice and I look at the patients we used to see at the Cleveland Clinic, I have women as young as 37 in their 30s, and actually even 20s if I included the athletes that I see, who have low bone mass or fractures, and as old as 98 to 100, where we're trying to prevent them from having a fracture and keep them living independently. So this is a huge age range, so it really impacts all women, not just at menopause, so before, after, and then and during.
Yes, I was seeing two patients today. One was a lady who had a sacral fracture just sitting, no trauma, just sitting, and in incredible pain. And another lady who hasn't fractured yet, but has severe osteoporosis and is too fearful of side effects of treatment. And so it is really a serious condition that doesn't get enough attention. And like now, menopause is so hot and everybody's talking about it, and people are even blaming things that aren't hormonal on perimenopause and menopause. I hope we get to that point with bone health, that people really start thinking about their bone health and being proactive and not waiting until they have that painful fracture. So you were a really early adopter of trabecular bone scoring, and I was the first at the clinic to do TBS. Now everybody else, all the other machines, the radiology department and endocrine and rheumatology have kind of caught up. So It was nice to do that positive peer pressure, but I found it exceedingly helpful. And I don't know if you want to talk a little bit about that.
Yeah, I think just like, we were going to chat about imaging first, and obviously the importance of osteoporosis is, can't be underscored, but you're right. Like the imaging that we have for bone density, I think that's one of the reasons why it's not as popular. Everyone talks about mammograms and getting their breast ultrasounds and MRIs. And in the bone density world, how we diagnose or how we, do a risk assessment for bone health is really, either a screening bone mineral density, which is essentially like a glorified X-ray of looking at your spine and your hips and sometimes your forearm. And it tells us, again, it estimates, it's about 60% of our bone mineral density estimates our bone strength. And so it's one of the best variables. And of course, we ask you all those questions about falls and fractures and dizziness in your medical history before, because that also helps us determine, what else is going on that might impact your bone density or your fracture risk. But that is good, but maybe we need other, techniques, just like a mammogram, we add on an ultrasound. So the other techniques that can help us assess bone strength, with maybe more certainty or, sort of more diagnostics, or could be something like a trabecular bone score, which is essentially looking at, it's a 2D grayscale image of the spine, and it helps us evaluate, not just the bones that are there, but maybe how the quality of the bones, or the microarchitecture, sort of that intangible quality of the bone might be. And it's helpful in women who have scoliosis and who have arthritis, because a lot of that density can be impacted or can be skewed when we look at a bone density. So this can sort of help that, our determination of your bone density a little bit better if you have those conditions. And also underlying conditions like autoimmune conditions or diabetes or rheumatologic conditions also. So it can be very, in addition, helpful to kind of give us an overall picture, just like other technologies. And this is where, again, you mentioned the radiographic, echographic multispectrometry. I always need to like revisit why they can't make that easier, but it's called REMS technology, which is essentially just an ultrasound way of looking at your bones instead of an X-ray that is with the DEXA scan, essentially. So it's just a different technology. it's also helpful. The issue is it's still not, validated as a scientific way to check the bone mineral density. The gold standard is still a DEXA, which is still very easy to obtain and very low amount of radiation. But again, there's other techniques that are out there that are growing in interest, potentially due to just being able to be more available, maybe more affordable, and also, hit a population that, of women who we're missing. So it's interesting technology. I think we always need to be open to things, but also check them, against our gold standards and our scientifically validated ways that we assess bone density.
I think that's very important. And, you talked about mammogram and all the different breast imaging that we have. I really think that in terms of bone health in postmenopausal women, that bone densitometry is a lot more precise and accurate and much less prone to overdiagnosis, which mammography can be, and underdiagnosis, especially with doing the clinical risk assessment and now being able to actually look at the bone microarchitecture for structure. Now, a lot of women are concerned about radiation. That's why there's a lot of women, especially in the age of three-dimensional tomo mammography, which is more radiation,
Right.
very concerned about having bone densitometry. So do you want to address that fear?
Yeah, for sure. I mean, I think we all need to be stewards of our own health. And I know that there are, we're just coming into, cold and flu season, so people might be getting an x-ray. So if we put that into, context, the radiation in a DEXA is about 1/100th of an x-ray. So it's a really low amount of radiation. If we look at like the, technical, it's, 0.1 microsievert. So it's really, really low. The dentist I go to has a great chart in her office about x-rays, and she has what eating a banana is the radiation, which is essentially just living, during a day. We get exposed to some radiation, talk about our phones and our devices and all of those things. So it's a very low amount of radiation. And if we think about a screening bone density that's essentially, ideally, done, around the menopause transition. So for some women that might be in their 40s, for some women that might be around their, mid to 50s, when we know that 95% of women are through the menopause transition between 45 and 55. So again, during that time, we should be doing a screening bone mineral density. And if it's normal, great. Most people say we don't need to repeat that for a couple years. Maybe that's an interval of 3 to 5 years. If there's some changes that we need to alert ourselves and make a, I call that osteopenia or low bone density, a stop and think diagnosis, and intervene, then we might want to recheck that in a couple years, the same way we would if there would be a abnormal pap smear finding or something on a mammogram. So again, women's health, where we need to, think of it beyond just like bikini medicine, that we're checking our cervix and our, our mammograms, but we're also including this other screening that's just as equally important, especially when we get in the postmenopause years where, women are living longer. So
one of the issues that I've dealt with trabecular bone scoring is it's not completely validated in all groups in terms of like long-term outcomes and knowing fracture risk, but ISCD wants us to evaluate and use it basically in virtually all patients, although there are body mass index limits to that. Mm-hmm. Do you have any idea when we're going to get that skin thickness correction? Because certainly if someone is very heavy just centrally, that kind of degrades the ability to take a look at the microarchitecture.
Yeah. So, just having my own machine and like you said, being ISCD certified, which is again, just, as we talk doctor speak, I think it's just helpful for people, listening. And, anytime you get a scan, either a mammogram, a DEXA, whatever, obviously you want the person who's doing that or reading that to like understand what they're looking at. And it sounds silly, but, some of the radiologists and some people just kind of, they just do this, but they're not really trained in understanding, like, how do we make sure we're looking at the spine correctly, or removing vertebrae, or understanding if you're on treatment, what sort of scores we need to give, or your age, or where you are in the time of menopause. So I just sort of go back to making sure that, like, yes, you're getting a scan done in a place that's reputable, asking them about their certifications, getting that report, asking the doctor who's looking at it if you really are seeing someone for bone health, that they're not just looking at a report, they're looking at the images. I'm such a stickler on that. Ask my staff for chasing down images and pictures and DEXAs, and I think I have my own DEXA and picture because when I sit down to read that, I am taking the whole story in, both the clinical story and the radiographic story. So it's really important. So we get good information in equals good information out. And so when you mention like the trabecular bone score, that can BMI, ethnicity, there's some variable, and even, this is validated to help us predict fracture risk. So for some of those, variables, ethnicity or BMI, it might be harder to read this exam for those people, or we haven't had the science to show us the direct correlation between low trabecular bone score and quote unquote fracture risk. And I do think that they have now changed. There is a skin tissue thickness upgrade on the DEXAs that can be done, just like any technology that can be updated through time. The biggest issue, and again, this is more technical than maybe our audience, is that it doesn't, the prior trabecular bone score cannot just be transposed or transfixed onto the new software. So you essentially get a new number. You get a new number. Bone score.
Yeah, that's a very good point. And also having women who maybe this isn't their area, this isn't their field, they're not technically necessarily oriented about bone imaging. But if you have the ability to go to a place that just focuses on bone densitometry, as opposed to a place that maybe the technologist and the person reading is a jack of all trades. They're doing ultrasounds, CAT scans, MRIs, plain films, and the technologist isn't ISCD certified, because when you're comparing, it is very important to have that precision. Yes. and know what your error rate is, because that can make big differences in treatment. Like, I'm confident when I see a patient back to say you're the same, you're better, or your test is worse, and this implies, a higher risk, meaning we might need to escalate therapy.
Absolutely. I mean, and I think this is where, bone density, it is specific, right? So it's not just what's your T-score? I think people are like, sometimes, I'll see a woman and she'll say, oh, great, my T-score is minus 2.3. Phew, I have osteopenia, not osteoporosis. And I say, well, that you're right, and that's great. We don't see, severe bone loss, which is osteoporosis, which is, again, the definition of microarchitecture and density changes that predispose you to a fracture. But actually, more women have osteopenia. We think in the United States, about 34 million women have osteopenia. That number is probably larger. And more women with osteopenia, or low bone mass is really the correct term, have fractures because there's just more of them. So you can still have a fracture or a clinical fracture, like a wrist fracture, or a hip fracture, a vertebral fracture, a forearm, pelvis, sacral fracture, as you mentioned your patient, if you have low bone mass, because bone density is one variable in our whole, fracture risk discussion. So if someone has osteopenia, they're still at higher risk for fracture. And guess what? They're only maybe 3% sometimes away from having actually osteoporosis and a BMD change. And we know that menopause, let's say, if someone comes to menopause with a bone density that's already an osteopenia, and they will lose anywhere from, in their spine on average, 7 to 10%, if that's based on our data that we know from the SWAN study, a study of women across nations that looks at women who go from perimenopause to menopause. That's an extreme amount of bone loss, and it can be even higher in the spine than the hip. So actually, if we're starting at minus 2.3 and we think you're going to lose that anywhere from 3 to 10% of bone loss, you will end up with osteoporosis if we don't do something. So very important when we rescan or when we scan that we're doing that either on the same machine or reliable machines that can be, what we call cross-calibrated or looked across time. So again, I think it's where we are starting from and where we're ending. And you're absolutely right. It's the devil is really in the details, is what I say with the DEXA.
Quite a bit. And also how long you live. Like the lady I was talking to today who didn't want treatment and was worried about some rare possible side effect with osteonecrosis of the jaw, which we don't even know if that's even a legitimate risk in the average risk postmenopausal woman without cancer or radiation. I said, well, if we have some big natural disaster and we both die in the next year, then you probably were fine and didn't need your bones treated. And I sometimes make a dramatic description like that because I'm trying to point out when we're seeing you today, we're not just thinking about your immediate risk for fracture in the next couple of days or a year or so. We're talking about assuming we can expand your lifespan and your health span so much that you're enjoying yourself and you want to be independent and functional, and not having major orthopedic surgery or in some rehab or nursing home because you've outlived your skeleton.
Yeah. And I think you're right. And that's what I think is so important, right, for what you've taught us at our fellowship, and also just, women learning or listening, even clinicians that are learning and listening, is that women's health really is something there. I think it's different than like endocrinology or rheumatology or other subspecialties. We really have to look at women across the decades, right? So, I saw a woman as young as 22 today. It was a patient of daughter of a patient who I see was polycystic ovaries. And then I saw, women in their 40s and women in their 60s and, women in their 70s, and every decade is different, right? And so you're right. Like if someone who has osteoporosis and they're 50 and they're on their first DEXA, actually, to me, that is more sometimes concerning than someone who has a T-score of minus 2.5 and they're 75 and haven't had a fracture, because they're being that woman who's 75 might be being treated or knows she has osteoporosis. At 50, you're coming to menopause with low bone density. If we do nothing and you live long enough, we can promise you will have osteoporosis and most likely a fracture, because 1 in 2 or 50% of women have an osteoporosis related fracture. So I think, again, it's decades of life. Where are you at your T-score? How is that changing? We know that there's some age-related bone loss in addition to the menopause transition. So again, we're so clinical. And I, saw a woman the other day who had seen me in 2022. I moved my practice. She, sort of has moved and then found my practice again. And we repeated her DEXA from, 4 years ago. And she had 6% of bone loss in her spine and 2 to 3% in her hip. And she's in the postmenopause, but that's because she's had just some age-related loss. She wasn't on her calcium. She didn't continue the hormone therapy because someone told her to stop, despite that was helping her genitourinary syndrome of menopause and helping her bones. So guess what? We reevaluated her, and she is a good candidate to continue hormones and resume hormone therapy. So we are going to do that for her. And she's 61, right? That's, again, everyone's an individual, but this is an example of what happens. We see time and time again when women, again, just get treated for menopause and not think about their bone density long term.
And you have been listening to the Speaking of Women's Health podcast. I'm your host, Dr. Holly Thacker, in the Sunflower House, with a recurrent and favorite guest, Dr. Kristi Tough-DeSapri, an osteoporosis and women's health expert. And we are talking about bone imaging and osteoporosis and the whole clinical and aging perspective to improve people's health span. Can you tell us, Dr. DeSapri, when might a woman prefer a REMS test compared to a traditional bone density DEXA test?
Sure. So, we kind of define both of them, and essentially, they are similar in what we're trying to look at, the bone mineral density, but just by a different technology, an ultrasound technology for the REMS and a sort of an X-ray type technology for the DEXA. So I'm spoiled / like have preferentially chosen to have a bone mineral density or DEXA scan in my office because it's the gold standard.
Yes.
Someone who might, but I do know that patients come to me with their REMS testing and they've had that done at potentially like a health center or a health clinic or a gym or a integrative medicine office that is caring, thankfully, about women's bone density. So I'm happy that they've done that test. And so a lot of women who might be, again, pregnant and have low bone density, we do know there's a small subset of women with pregnancy and lactation-induced osteoporosis, someone who has maybe a significant amount of degenerative spine changes, things like that. Again, this is discussed more maybe in like a rural setting or a setting where there's less tertiary care. I'm here in the North Shore of Chicago, so we have plenty of that. But I know that when I go do my lectures in Indiana and in other places, Iowa and Wisconsin and Michigan, sometimes around here, there's less access, to just, to imaging and physicians and clinicians in general. So those are really the areas that I see. And I think, again, there are some studies, and we both have read them about, validation of how much, how much similar overlap there is between DEXA and REMS. And some studies say yes, and some studies say no. I think it is very much dependent on the operator or the radiologist or the person who's doing the scan to make sure that they're scanning the right area, they're doing it correctly, they're obtaining the right information. And again, the REMS, I think, tends to say that, there's a sort of a fracture score. And if women are on the younger side, again, closer to the menopause transition, the fracture or the fragility rate is going to be lower. And naturally, we know that because the balance and posture and fall risk is much lower generally when we're, in our, less than 65 or less than 70. And a lot of, men and women would look over all the data over time. But it still doesn't mean that your risk of osteoporosis for a lifetime or your chance of developing a fracture later in life is not high. It just says that your risk of fracture right now is low. And so that is one thing that when I look at the reports and I compare when I've done a DEXA and someone brings me a REMS, the difference, in terms of, and that's probably what you see, but I'd be curious.
Yes. And I just see that in this field that in women, we really do have a lot of good research. We really do have so many options, non-hormonal, hormonal. There's lots of choices and we can really individualize it. It just seems like there's this intrinsic gut reaction that women don't want the imaging, or they don't want to pay attention to it if it's particularly bad, or they don't want to take therapy, or they just say, I'll just go exercise. And they're always looking for something else than maybe what we know works and can evaluate and treat women and really reduce a lot of problems. A lot of women are coming to me and they're saying, oh, what about that prune study? I could just eat prunes instead of taking my osteoporosis medicine. And there's just a lot of looking into other things, which I'm all about being holistic and boosting the vitamin D3 and K2, making sure there's not other secondary causes. Like I pick up so many secondary, causes from low vitamin D to celiac to hypercalciuria, from a genetic leak in the kidneys. So there's a lot of things that we can do besides standard hormone therapy and osteoporosis medicines. But I just wish that the general public and women in general had a little bit more urgency, because if they haven't seen women through the lifestyle, or they're still looking at themselves through the lens of being a healthy 20 or 30-year-old, and they thought that their mother's hip fracture was, just because mother was old or because father was climbing up on a ladder and he fell, that there just still seems to be so much poo-pooing of the seriousness and the fact that we can get ahead of this. We can prevent, we can treat. We've got so many excellent options.
Right.
And I just wonder, is that your experience?
I think I think the issue with the REMS, particularly when we look at the DEXA, is that, right, it does tend to sometimes underestimate like the fracture risk, or the definitions are like you're of a lower fracture, or your fragility score is low. But for many women, particularly, again, I'm seeing primarily women 40 to 60 getting these tests who haven't had established osteoporosis, or who are, just trying to understand or do a comparison. Again, that underestimates your fracture risk for lifetime. Sure, you might be low risk now, but and that's where, like, again, how can we quantify some of this? So this is where using like a T-score diagnosis, which means, again, if you're osteoporosis, your 2.5 T-scores, or your 2.5 standard deviations from a normal strong bone density, which of course there's some age related losses. Remember, there's some genetics that determine our peak bone mass. And so some of that we can't handle, but we know that those are, regardless of those are risk factors for fractures and for future osteoporosis. So sure, we can blame our parents and our genetics all we want, but like you said, it still might catch up with us, and then what, right? And I think we hear that a lot more in cardiac testing now, that we're checking Lp(a) and ApoB and doing advanced lipid screening, where people say, I eat a Mediterranean diet, yet I still have an Lp(a) of 300. Well, that's there's only so much salmon and omega-3s that are going to change that, you know? So,
but oral hormones do reduce LP-A
they
by
sure do.
20%. And we finally have some cardiologists, talking about that.
Yeah. So again, and so it's putting what we have in front of us and then making some decisions. And that's where like the fracture risk assessment or the FRAC score can come in. So it tells us what is your percent, over the next 10 years that you will have a major osteoporosis related fracture or a hip fracture. But again, women in their 50s and maybe even 60s may be low.
Mm-hmm.
But again, if you add 10 more years, we know that then will double. And so that risk is actually, when we think about the risk of a hip fracture or a major osteoporosis related fracture that's over 10%, that's actually equal to the risk of getting breast cancer through the lifetime, which is a 12% risk if women, again, live until 90 to develop breast cancer. And if your risk of a hip fracture or a major osteoporosis related fracture is over 10%, we recommend to treat you because we can actually lower that risk. And oftentimes by 50% or more, regardless of the treatment we use, hormones, bisphosphonates. And then if you're very high risk, of course, we're using the bone building agents and talking to you more in depth about those. But so that's what I mean. We have to look at the numbers and the percent of that you have for your risk, and then say, well, we can actually half that, or we can significantly reduce that. I kind of call it a lot of like bone health insurance of what we do, right? We're ensuring you're getting, your vitamin D and your calcium so that we can mineralize and strengthen your bones so that, the medicines that we use work, or the jumping and the resistance training you're doing are adding on to those things, right? And I'm sure you use a lot of those same analogies, because I don't think it's just medicine, and I don't think it's just the exercising more. We know that, right? We know those things don't work in silo well.
Absolutely. And you mentioned breast health, and that's one advantage about seeing a osteoporosis and women's health expert like yourself, and like many physicians I've trained over the years, and as well as many of our APPs that are interested in the field, is that we have bone agents that also can reduce breast cancer risk, like hysterectomized women on oral conjugated estrogens have reduced risk of breast cancer. Women without hot flashes who don't want hormones, we have relaxafen, Evista, which has been shown to reduce estrogen-positive breast cancer. And so we can really kind of tweak that and look at the woman's stage in hormonal life. And it's not that we want to overtreat women. One of the big benefits that I've always seen, very healthy, very thin, petite women who've never broken a bone, who have great dentition, a nice straight back, but they had osteoporosis based on their 2 standard deviations below the average 30-year-old woman. And when you get that normal trabecular bone score, which I think gives us so much more information and power than maybe just looking at an ultrasound, test, then when you have normal bone markers and maybe the woman's on hormone therapy for longevity and anti-aging and plus minus menopausal symptoms, you can be confident that you don't have to jump to another therapy, another traditional therapy.
Yes. Yeah, exactly. I mean, again, it comes down to like you're saying, individualizing, and also just looking at the woman's age and stage, right? Of like where we're at. But and you and I have both seen that woman you just described, but then also that woman you've just described who maybe is in their 50s and has had a fracture or is higher risk. And I saw a woman today with a minus 4.1 T-score in her spine who, is in her 50s. Of course, you mentioned it quickly, but it is so important that we do, look for other causes. The statistics are pretty high. I mean, they say 30% of women with osteoporosis might have an underlying condition. I think that is higher than I usually see, but it always is important to, rule out malabsorption and, like you're saying, the 24-hour urine calcium. I see a lot of people sometimes just have a great case. I mean, unfortunate case, but thankfully she found her way to us, is that she had osteoporosis and she went to, a subspecialist, and they just said, yep, thin Caucasian female, we're just going to give you alendronate. And yet she had high calcium on her blood testing, and they said, stop your calcium supplements. And she said, I'm not taking any calcium supplements. And then they called her back and they said, we'll check it. And they said, stop your calcium. And she said, I'm not taking any calcium. And thankfully she had the wherewithal to say, this is probably not someone who's listening. And,
right.
Turns out she of course has, hyperparathyroidism and a large thyroid adenoma, high calcium in her urine and other symptoms. So this isn't just garden variety osteoporosis, right? This is something else. We're going to take that parathyroid hormone, that parathyroid gland out, and we're also going to treat her osteoporosis. So, again, important to always be looking for those, secondary causes and, again, evaluating. And if someone is high risk, right, my point was that we use hormones, but sometimes we also need to use hormones and something else. So sometimes we need to also augment the therapy and give a bone building agent or something in addition, so that we're not just saying, well, let's cross our fingers and hope the hormones are doing it. We'll maybe need to think about something else in addition. So I think that's where, again, medicine isn't like longevity medicine and women's health medicine. We're working together, we're thinking about the long game as well.
Well, as we wrap up this terrific interview, tell us a little bit about your practice and how listeners can learn more about you and maybe potentially see you in your practice.
Yeah. So I always say that I started my practice and I try and, really have, how can I say, sort of fashioned it after like the care that we used to give at the Cleveland Clinic, because I do feel that, this day and age, we all know how medicine is fragmented and women's health is sometimes rushed, and, we are complex. We were saying we are complex beings. So, especially at menopause, all the factors that come in from head to toe, our hot flashes, our brain fog, cardiac health, breast health, GYN, urogynecology, musculoskeletal syndrome of menopause, osteoporosis, libido, sexual health, so many things that we address. So I'm very lucky and honored that I get to spend a lot of time with patients to talk about these things and then see them back. So I have a direct care practice on the North Shore of Chicago. So most of my patients see me in person, but we obviously have a ton of snowbirds. So I think today I saw 2 people from Arizona who were here after the holidays. So that is our practice. I have a DEXA scanner in my practice, and we do, routine gynecologic care. We do a lot of coordination of care, subspecialists if it's something we like, urogynecology or women's psychiatry, where I feel like, someone could also help us in this way and make our, your health better. So that has been a really fun part of what I've done and learned a lot from those subspecialists. And then I do see some patients virtually, mostly just obviously for bone health, or try and connect them with someone. We have a great network of women's health providers across the country. So try and connect them there. But I do see women with maybe more complicated osteoporosis who want to see me, virtually, send me their DEXA images and really get into it, or if they need a second or third opinion there.
And tell us what your social media and your website. I know you've got a great Instagram.
I do. That is one of my New Year's resolutions, to work on that a little bit more. I love the science and writing and things like that. So I'm working on that, but it's so important. So I do some Instagram on just Bone and Body WH, and I have my website, which is boneandbodywh.com, and we have a newsletter there. I pour some information into, so that's really where I, get the writing and just be able to share, some updates in women's health and translate the science.
Well, that is terrific. Thank you so much, Dr. DeSapri, for joining us and giving us the insights on bone density. And thanks to our listeners. If you haven't already, please share the podcast with friends and family and encourage them to subscribe or follow. And if you enjoyed this podcast, give us a 5-star rating. We'll be back next week with another episode. Until then, remember, be strong, be healthy, and be in charge.